Welcome to this JACC podcast on papers that we're going to be featuring from presentations at the ESC meeting with simultaneous publication in JACC. I'm Theresa McDonagh. I'm one of the associate editors of JACC, and I'm a cardiologist at King's College Hospital in London. And I have the privilege today of speaking with two of the authors of a couple of papers, both from the Brigham and Women's in Boston, John Ostrominski, Muthiah Vaduganathan. Maybe you want to introduce yourselves a little bit more comprehensively.
No, that's terrific. And so once again, Theresa, thank you so much for having us. It should be a lot of fun to chat about these two kind of very synergistic and thematically related works. And again, my name is John Ostrominski, and I'm a fellow in cardiovascular and obesity medicine at the Brigham in Boston, and work very closely with Muthiah.
And thank you, Theresa, as well for your time and as well as all your efforts at JACC. Muthiah Vaduganathan, I'm a faculty and assistant professor at Brigham and Women's Hospital and Harvard Medical School. I'm co-director of the Center of Cardiometabolic Implementation Science, and so excited to discuss these works.
Okay, so let's start with the first paper, which is an individual patient data meta-analysis of 5 HFpEF and HFmREF studies, DELIVER, iPreserve, Paragon, Charm Preserve, and TopCat, really looking at measures of obesity and cardiovascular outcomes. So John, maybe you want to take us through the main messages of this really nice paper.
Yeah, absolutely. And I would say kind of the two kind of questions we were really kind of hoping and kind of aiming to address were kind of related to this key question of whether or not BMI should be the primary measure actually to define obesity, and additionally whether it should be really the primary measure also to enhance adiposity-related risk stratification in individuals with heart failure with mildly reduced or preserved ejection fraction. And so the first question was, if we were to take everyone in these trials, what would be the prevalence of BMI-defined obesity or the prevalence of kind of any excess adiposity if we incorporate additional measures of adiposity, specifically waist circumference or waist to height ratio? And we found actually a very interesting message that was notably aligned from some prior work, and that when we actually use BMI alone, less than half of this pooled population of nearly kind of approximately 21,000 individuals had obesity, as defined using kind of those strict BMI-based thresholds. When we incorporated actually, though, additional anthropometrics, specifically waist circumference or waist height ratio, we found the prevalence of excess adiposity or of abdominal obesity to be much, much higher. Actually, over 9 in 10 of these participants actually had obesity when defined incorporating these additional anthropometrics. And so I think, one, that's a very, very important message for individuals who are caring for people with heart failure, and that consideration of these broader anthropometrics may substantially enhance the identification of obesity in clinical practice. The second key message was, it relates to kind of this important research question of, well, how does obesity associate with various different adverse outcomes? And we know from prior work that actually once heart failure is established, the association between BMI and adverse outcomes really becomes quite complex. And essentially, one, it's very U-shaped, but the key, I think, theme that and key term that many have likely heard of is this term called the obesity paradox, which essentially reflects a right shift of the normal U-shaped distribution such that individuals with usually kind of a BMI of around 30 appear to paradoxically have the least risk of certain health events, including mortality events. But more recent evidence has suggested that this complex and somewhat paradoxical association may be attributable to the limitations of using BMI as a metric. And other anthropometrics, again, like waist circumference or waist to height ratio, may actually have simpler and more direct associations with outcomes. And so across a wide range of clinical outcomes, specifically mortality and heart failure events, we actually reproduced the obesity paradox, quote unquote, for mortality events. But notably, when we used other anthropometrics, including waist to height ratio, we found actually that even for mortality events, that these additional anthropometrics actually had much more linear associations, such that with individual increments in waist height ratio or waist circumference, there was a much higher incidence of all of these events. The other important, I think, additional finding was that we found these associations to be highly modified by age. And while higher adiposity was associated with adverse outcomes across the age spectrum, we found the steepest associations actually for younger individuals with heart failure.
Yeah, that's very interesting. And I presume clinically the message we take from this in assessing HFpEF patients there is don't just measure BMI, it's better also to measure waist circumference or waist to height ratio.
Great. I completely agree. Agree. And I think especially to identify obesity and then to enhance kind of the global adiposity related risk stratification.
That's great. Thank you very much. Well, we'll go on to the second paper, which is on the same theme. And Muthu, you're going to maybe talk us through this. This is again an individual patient meta-analysis, but this time of trials involving finerenone across the cardiovascular, chronic kidney disease, metabolic disease spectrum, and looking at the role of how finerenone acts with these various measures of adiposity. So maybe you'd like to tell us the highlights of this, Muthu.
Thank you, Theresa. And this is really intended to expand upon the first paper and expand on this focus around cardio-kidney metabolism, or CKM. So this united data from 3 individual patient-level data streams, the Fidelio DKD, Figaro DKD, and Fine Arts population. These span patients with established heart failure and established chronic kidney disease. And again, the same findings rang true, that in this pooled population, if we assessed BMI alone, and a BMI, let's say above 30, was present in about 52% of individuals. If we take a broader assessment of any level of adiposity, including waist circumference-based measures, there we get about 98%, or adiposity is almost universal in this HFpEF population, this heart failure and CKD population. So this again underscores this thematic link of CKM, that adiposity is a central driver of CKM progression. And in fact, this will be a highlight in the JACC obesity session at the ESC, where the adipocyte hypothesis will be put forth by Professor Packer, as well as other colleagues, and really focuses on this notion of universality of adiposity in this syndrome. The second key findings were again very similar to the HFpEF populations, that even after accounting for BMI, these additional measures of adiposity were strongly and independently correlated with adverse risks of not just cardiovascular, but broad systemic health outcomes. And finally, the safety and efficacy of finerenone were entirely consistent across a broad range of adiposity. And importantly, because those with higher adiposity faced higher absolute risks, the absolute benefits too were highest in that population. So my take home here is again that a broader focus on adiposity as a whole, rather than a narrow focus on BMI, is warranted for patients with CKM, or cardiovascular kidney metabolic syndrome.
So thanks very much. So a consistent message from both of these papers that we should be looking at, in addition to BMI, waist circumference and waist circumference derived measures of obesity, waist to height ratio, waist to hip ratio, as they are more informative for prognostication for our patients. So thank you both for joining in the podcast. Congratulations for your presentations at the ESC and simultaneous publications in JACC.